Welcome to our in-depth exploration of factitious disorder, one of the most perplexing conditions in mental health. Over the next 10 minutes, we'll examine this complex disorder characterized by the intentional falsification of medical or psychological symptoms, its various manifestations, the motivations behind it, challenges in diagnosis, and approaches to management and treatment. Factitious disorder represents a puzzling intersection of medicine and psychology. According to the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, this condition involves the deliberate falsification of physical or psychological symptoms, or induction of injury or disease in oneself or others. What distinguishes factitious disorder from malingering is the absence of obvious external rewards such as financial gain, avoiding work, or obtaining drugs. Instead, individuals with factitious disorder appear motivated by a psychological need to assume the sick role, gaining attention, sympathy, and care through their apparent illness. The disorder exists in two primary forms. In factitious disorder imposed on self, individuals falsify their own physical or psychological symptoms. In the more severe and troubling variant, factitious disorder imposed on another, previously known as Munchausen Syndrome by Proxy, a caretaker falsifies or induces illness in a person under their care, most often a parent creating illness in their child, though it can also involve caregivers of elderly or disabled individuals. Both variants represent serious conditions with potentially severe consequences for all involved. The history of understanding this disorder is fascinating. In 1951, physician Richard Asher first described a pattern of hospital-hopping patients who fabricated dramatic medical histories, naming it Munchausen Syndrome, after Baron Munchausen, a historical figure known for fantastic tales of adventure and survival. Later, the broader term factitious disorder was adopted to encompass the spectrum of illness falsification behaviors beyond the extreme hospital-hopping cases. The term Munchausen Syndrome by Proxy was introduced in 1977 by pediatrician Roy Meadow to describe cases where parents fabricated illness in their children. To understand what factitious disorder looks like, consider James, a 42-year-old man who presented to emergency departments across 3 states with dramatic reports of hemoptysis, coughing up blood. He arrived with detailed medical records, later discovered to be falsified, and knowledge of medical terminology, suggesting previous hemoptysis episodes requiring intensive care. Upon admission, he would contaminate his sputum samples with his own blood to create false evidence. Despite extensive testing revealing no underlying disease, James would discharge himself when confronted with inconsistencies, only to appear at another hospital with the same complaints. His case illustrates several hallmarks of factitious disorder: medical sophistication, treatment seeking across multiple facilities, and evidence manipulation. The manifestations of factitious disorder are remarkably diverse and creative. Physical symptoms may be falsely reported, completely fabricated, exaggerated, based on minor actual symptoms, or actively induced. Some individuals contaminate test samples, such as adding blood to urine specimens. Others may self-inflict injuries or infections, inject foreign substances, manipulate thermometers, or interfere with wound healing. Psychological symptoms are also commonly fabricated, with individuals presenting dramatic but atypical symptoms of conditions like post-traumatic stress disorder, schizophrenia, or dissociative identity disorder that often incorporate elements from media portrayals rather than clinical reality. In factitious disorder imposed on another, caregivers may falsify symptoms through deceptive reporting, specimen contamination, medication tampering, or direct induction of illness or injury in the victim. These cases represent a serious form of abuse requiring immediate intervention to protect the victim, who is often unaware of the deception. The victims may develop genuine medical problems from unnecessary treatments or procedures, creating a particularly complex clinical picture. The prevalence of factitious disorder is difficult to establish precisely due to the secretive nature of the condition, but studies suggest approximately 1% of hospital patients may have the disorder. It occurs across gender, socioeconomic, and cultural lines, though factitious disorder imposed on self is somewhat more common in women, while both genders are relatively equally represented in factitious disorder imposed on another. Interestingly, many individuals with factitious disorder have healthcare backgrounds or extensive exposure to medical settings, giving them the knowledge to create convincing presentations. What causes factitious disorder? While no single explanation accounts for all cases, several patterns emerge from clinical research. Early childhood experiences often play a role, particularly histories of emotional neglect, physical or sexual abuse, or serious childhood illness. Many individuals with this disorder experience disrupted attachments with caregivers, learning that illness was the primary or only reliable way to receive care and attention. Some experience childhood trauma in medical settings, yet paradoxically seek to recreate medical scenarios where they have more control. Psychological dynamics frequently include identity disturbance, with the illness identity providing a sense of coherence otherwise lacking. Many struggle with regulating emotions and managing stress, using the sick role as a maladaptive coping mechanism. The hospital environment may provide a sense of safety, structure, and belonging that they cannot achieve in other social contexts. For those with healthcare backgrounds, the disorder may represent a distorted attempt to enter the healing profession from the patient side when direct caregiving roles have been frustrated. In factitious disorder imposed on another, additional dynamics may include pathological need for attention from medical professionals, desire to be seen as a heroic or devoted caregiver, or underlying personality disorders involving manipulation and control. Some perpetrators appear to develop unusual satisfaction from deceiving authority figures, particularly medical professionals. The relationship with the victim is typically characterized by pathological attachment and boundary disturbances. Neurobiological research, though limited, suggests some individuals with factitious disorder may have subtle brain differences affecting impulse control, reward processing, and attachment systems. Genetic factors potentially influencing personality traits relevant to the disorder are being investigated, though much remains to be understood about the biological underpinnings of this complex condition. Diagnosing factitious disorder presents extraordinary challenges. By definition, individuals with this condition actively deceive healthcare providers, creating elaborate false histories, manipulating physical evidence, and studying symptoms to present convincing clinical pictures. According to DSM-5 criteria, diagnosis includes falsification of physical or psychological signs or symptoms, presentation of oneself or another as ill, behavior evident even in the absence of obvious external rewards, and symptoms not better explained by another mental disorder. The diagnostic process requires careful detective work. Warning signs include symptoms that change or worsen when the person is observed, treatment resistance, eagerness for invasive procedures, extensive knowledge of medical terminology, history of seeking care at multiple facilities, peregrination, and vague or inconsistent medical history. Laboratory discrepancies, such as blood types that don't match records or toxicology findings inconsistent with reported medication use, often provide crucial clues. For factitious disorder imposed on another, suspicion should arise when symptoms occur only in the caregiver's presence, the reported history doesn't match objective findings, treatments aren't effective despite being appropriate for the alleged condition, or the caregiver appears unusually calm or even gratified by the child's or dependent's illness. Healthcare facilities increasingly use video monitoring in suspected cases, which has proven invaluable in documentation. Confronting individuals with suspected factitious disorder requires extraordinary care. Direct accusations typically trigger denial, anger, and abrupt departure from care, a phenomenon termed discharge against medical advice, or the Houdini Effect. Most experts recommend a non-confrontational approach, gently suggesting psychological factors may be influencing physical symptoms while avoiding direct allegations of deception. The goal is maintaining the therapeutic relationship while redirecting care toward addressing underlying psychological needs. Treatment of factitious disorder is challenging, but not impossible. The cornerstone of management is establishing a consistent relationship with a primary care provider who coordinates all medical care, reducing opportunities for doctor shopping and unnecessary procedures. Clear boundaries around healthcare seeking, admission criteria, and acceptable behaviors must be established. Medical interventions should be minimized to those absolutely necessary for symptom management, avoiding reinforcement of illness behavior through excessive tests or treatments. Psychotherapy, when individuals are willing to engage, focuses on developing healthier ways of meeting emotional needs, processing earlier trauma, improving interpersonal relationships, and constructing identity beyond the sick role. Therapy approaches including psychodynamic psychotherapy, cognitive behavioral therapy, and dialectical behavior therapy may be beneficial depending on the individual's specific needs and willingness to acknowledge psychological components of their condition. For healthcare systems, creating alert systems that identify patterns of healthcare seeking across facilities while respecting patient privacy concerns has proven helpful. Case management approaches coordinating care across providers and settings reduce opportunities for the splitting and manipulation that often characterize these cases. Staff support is essential, as these cases frequently evoke strong emotional responses in healthcare teams ranging from anger and betrayal to excessive sympathy and rescuing behaviors. In cases of factitious disorder imposed on another, intervention must prioritize the victim's safety. This typically involves child protective services or adult protective services, law enforcement, and often legal proceedings. The perpetrator requires specialized mental health treatment, but prognosis is guarded, with high rates of treatment resistance and recidivism. The victims need careful physical and psychological assessment and treatment for any genuine medical conditions and the psychological impact of the abuse.